Welcome, everybody. I had just opened up the waiting room, so I'm going to give it a few seconds to let everybody join. Make sure you can connect through. I'm going to go ahead real quick and point out that we do have the chat feature. So if you would like to use that for any comments, you can. In fact, if you want to give it a quick try, let us know where you're joining from. That would be great. Just click on chat and type in something. I am here in Schaumburg, Illinois. We've got Georgia. Very cool. Hi, Wendy. That's awesome. Um, let's see. Florida. Oh, I wish I was in Florida. So, hey, Barbara McCormick, how are you? From New Jersey. Good to have you here. All right, well, I'm going to go ahead and get this started for everybody. Again, that chat is available for you. Go ahead and use that to make any comments and let us know where you're joining from. Say hi. If you know somebody who's here and you want to say hi to them, you can do that as well. I do want to point out the Q&A tab. The Q&A tab is where we'd like you to put your specific questions. So you click on that and it will show you how you can go ahead and click Q the question part, and then we have people watching the Q&A, and we will have time at the end also for additional Q&A. So feel free to go ahead and put your questions there. As you can see, you're joining the Emergency Nurse Residency Program webinar, what the data shows. And I'm going to go ahead and turn it over to ENA's Director of Education Programs, excuse me, Monica Escalante Colbuck, who will be leading today's webinar. So go ahead, Monica. Thanks.
Thanks, Nan. Hello, everybody. Thank you for taking the time today to join us. Again, my name is Monica Escalante Colbuck. I am the Director of Education Programs here at ENA. So my team and I, we oversee ENA's Emergency Nurse Residency Program, which is the reason why many of you are here today. We also oversee our triage portfolio and all novice nurse education. So I have been an emergency nurse for 20 plus years. Clearly, I began nursing when I was 5, and I went straight into the ED after nursing school, which is one of the major reasons why I'm a huge supporter of this program. So I'm going to get us started. There are some times I'm going to ask you to type some stuff in the chat, um, and respond to a couple poll questions as well. So the first thing, I want to talk about is the current state of emergency nursing. One of the biggest things I like pointing out is when you look at the data, nearly 1/3 of all newly hired nurses leave within their first year. I'm sure many of you know this, and this is why you're on today's call. But this early departure disrupts a lot of things for us. Staffing, workload. It creates a huge impact um, on the teams that are remaining, those that choose to stay, right? That adds another significant strain on them, but also it adds a huge significant strain, financial strain to the hospitals, which creates a lot of operational challenges for many of those who are leaders. So, out of curiosity, if you know, for those of you on the call today, for those of you who know, I want to see, do you know what your ED turnover rate is? If you do, toss it in the chat. So what you're seeing here, you see on the graph on that right side, the ED is a high stress. It is unpredictable environment. We know that, right? But you look at nationally, the turnover rate among new grad nurses remains such a problem. The average is 16.4%, and that's within the first year. So now I want you to see right here and focus on that. The ED is averaging above the national rate. We're at 19.1%. Sure, you can account for maybe it's unpredictable, it's high stress, they're leaving because they can't hack it per se, but there's a lot more things that we could be doing in that time frame. And what the research is suggesting is that it's more than just burnout. There is a definitive pattern to when nurses are choosing to leave. And it's really in that first year of practice. That time is critical, and it's a critical transition point in their career. So the first year, yes, we know it's a steep learning curve, and it comes with transitions, shock, emotional fatigue, a lack of consistent mentorship, all of which all contribute to job satisfaction, dissatisfaction, and turnover. So this pattern really underscores the need to have us focus on what is going on during that first year. So, it's an operational challenge, right? For those who are CNOs and directors and managers, we know what the cost is. So onboarding a single emergency nurse costs anywhere from 40,000 to upward to 80,000, depends on, the geographic area and all that stuff in the specialty. The average being about 61,000. So for every 1% increase in turnover, that is 289,000 in organizational costs. That's a lot of money. And then you add up, and that's just for one nurse, right? So then if you keep adding that up, and that's a big financial burden for hospitals. So as turnover increases, hospitals are what? What are we doing? We rely more on overtime. Maybe we're pulling in travelers, temp staff, which that is not sustainable plan, and it is definitely costly and increases our overall labor costs. So surely it's not a sustainable plan for us moving forward. So the other operational challenge is it disrupts the workflow. We have increased wait times. We strain the hospital efforts to meet our safety and metrics. We know we still have to meet those metrics, and you have to do it with less staff. So it makes it a lot more difficult. Ultimately, what I'm saying is that the financial burden of turnover directly contributes to our operational instability as well. So I want to take an informal poll here. Who here on this call has heard of or actually knows what ENRP is? Before today, before me talking about it. All right, while you guys are doing that, today I'm not going to go in depth about residency or our ENRP program. Of course, if you're interested, we can certainly provide an in-depth review at another time. In fact, I believe someone from my team can put in the chat who to contact, and at the end, I'll have a QR code for you to reach out to our team. So ENRP is a specialty-specific nurse residency program. I want to see the results. Can you launch that, Nan, so I can see what the results are? Okay, 76%. Good. Good. Okay, so the 24% of you, hopefully you'll be reaching out to us so we can deep dive into what our program is all about. I'll give a brief overview though, so at least you'll have an idea. So it is a specialty specific nurse residency program. It's turnkey. It's designed exclusively for emergency departments. It's not your generic or generalized, I should say, onboarding program that's been adapted for the ED. This was truly developed by emergency nurses for emergency nurses. It provides structure first year support during what we know to be the highest risk period of turnover. And what we're doing is creating consistency, standardizing how new emergency nurses are developed across cohorts that come in. So I can give you a brief overview of like what it looks like. And if not, you can scan the QR code to our landing page and dive into it a little bit more. So it's no secret that the ED is a difficult environment to work in. And it's very well known in the literature that structured emergency or structured residency programs in general have been shown to improve confidence, skill acquisition, and retention. So our curriculum, so you can see on the right-hand side, we have the didactic topics that we go over. The curriculum is standardized. So what that does is it reduces the variability in training while also enabling local operational flexibility, meaning you can add in things that are maybe specific to your hospital. It is delivered through blended learning. We want to make sure we capture all different types of learners. So we have didactic in class, we have simulation, we have online asynchronous modules. So we blend the learning model and that we combine it with like real-time clinical integration. So the time they're spending with their preceptors. It's evidence-based. It's written by board-certified emergency nurses here at the ENA. With it, you could see there's classroom case studies. We have lectures, slide notes, instructor tips, and the rest. So one aspect I think of the program that people tend to overlook is that it's very preceptor aligned. So we provide our hospitals who obtain the program with the education, the support that they need and the clinical expectations for their preceptors to help them understand pace progression and reduce some of the cognitive load for them as well. So for some of our hospitals, we do provide in-person preceptor workshops as well. There's a lot more to the program. That was just a brief recap of it. So you can go ahead and scan the QR code if you're interested in diving deeper. For today, I know everyone's interested in seeing the data. So let me preface it real quick with to evaluate program effectiveness, we're using so our data source and what our methodology is. So we use the Casey Fink graduate nurse survey. So let's try some heart emojis. Click on and use your heart emojis if you know what the Casey Fink graduate nurse experience survey is, or if you use it in your ED. So Casey Fink survey provides validated measures of new nurse self-efficacy, belonging, and satisfaction with preceptor support. We also build a program evaluation into Qualtrics, and we pull that data into a Power BI dashboard that was created by ENA research team and our data analytics team. Our initial approach involves descriptive analytics to identify patterns and relationships within the data. Our goal would be to move ENA past the descriptive analytics and toward predictive modeling, which is, of course, way down the road, but it is something that, we're looking into. Eventually, we'd like to map out like which of the factors most strongly forecast retention. So before actually, why don't we jump in right to the data? Let me go to the dashboard. Okay, so what are we measuring? Um, I guess throw in the chat. I'm kind of curious. What kind of data would you want to see in a nurse residency program? I guess what is the information that you would need to convince you that our program works? So are you curious about retention? Are you curious about satisfaction with their job? I'm curious to see if you throw that in the chat. I want to see what some of you are really looking for. All right, what we do measure is retention. We measure their intent to stay, confidence in clinical decision making and skills. And that's like it's a leading indicator of safe, independent practice in the ED. We also measure professional belonging and transition stress. So I see, thanks, Shannon. I see the retention and job satisfaction. Patient outcomes is a tough one because that involves us being there in person to do chart reviews and stuff. But we definitely are looking to team up with hospitals to be able to get to that point where we can actually do patient outcomes. That would be the ideal goal. So intent to stay, obviously, I know I talked about that a little bit, but together, all of these measures enable us to not only see whether the nurses are completing the program, but whether they're more likely to stay. The data I'm about to show you is cumulative, and it's based on all of our current ERP clients. So success rates, I'm looking through the chat to see if I'm missing something. Retention is a big one for us. Yeah. You'll be surprised when you see our retention. Effect on quality care versus not. Yeah. Good. Okay. We have had our program in critical access hospitals all the way to academic medical centers. So ENRP, Emergency Nurse Residency Program, is in about 30 states. We are going on our fourth year. We're serving all sorts of hospitals, from critical access hospitals to academic medical centers. Keep in mind this program is barely 4 years old. So this is a snapshot of who the ED residents are across all participating hospitals. We can see demographic patterns here: age, gender, race, ethnicity, as well as prior experience, educational background. Why does this matter? Why do we care? We like to give this information back to our hospitals so they can also reflect on, who am I hiring? If I have any DEI programs, am I meeting those goals? Looking at pre-licensure nursing degree obtained, and am I working with local universities, nursing schools, colleges, and any type of programs? So what this takeaway on this slide really is showing that over 60% of the participants are under age 30, and nearly 70% of them have no prior experience in any other clinical area. So meaning these are truly new nurses that are entering the field. Um, they probably wouldn't, right? Or the clinical experience, maybe they did go to I don't know, med surg for 2 months and then decided I wanted to try the ED. Like, so that could be some of the variations in the years of practice. So residency length, I'm going to point that out. It varies significantly with, well, I shouldn't say significantly, but with most of the programs, they run about 13 weeks or longer. Some of our hospitals have transition nurses, so nurses new to the emergency department, but not new to nursing. So those types of nurses may have a shorter residency a week. So that's why you see some of the variations. Also, some of the residency programs, the hospitals we have been able to condense their residency time. So anyway, this data helps us kind of understand who's in our program, who are we training, and identifying any trends in the structure and set the really set the foundation for more predictive. All right, now I'm gonna take a look at confidence levels. So across every domain, and actually maybe I should have said this in the first slide. That's okay, I'll do it now. So you see the number of total participants, 232. That's not reflective of the actual number of nurses who've gone through our program. Like anybody here, I'm sure you know what it's like to send out a survey and have people respond. So we're no different. We send out surveys, we do the program evaluations, and it's so tough to get the nurses to go and fill out the evaluation. So it is a good representative number, but we certainly have had a lot more than 232 nurses go through our program. In fact, I'm probably going to put Katie on the spot. But Katie, if you can look up the number of nurses that have gone through the program, throw it in the chat whenever you get a chance. That would be great so people can really see how many people have gone through it. Anyway, so jumping back to confidence, across every domain, you take a look here. Over 95% of the nurses agree or strongly agree they're confident in prioritizing care, recognizing changes in patient condition, communicating with providers, making clinical decisions, and those are fundamental to safe, effective practice. So what stands out to you is it should be that the majority of these nurses are feeling confident. I'm curious, throw in the chat. I want to see what is on this screen. What is the one thing that you really feel is impactful to you, like that that you would love to see in your emergency department? Um, so what else is this data telling us? You'll also notice that fewer strongly agrees, responses in areas like workload management and delegation, and that's pretty much what we would expect, right? Early in their practice. Um, the value of residency is that it provides structure and support while those skills develop, rather than leaving nurses to figure it out on their own. So as we identify gaps, that can help us pinpoint where nurses may be more vulnerable and lay the groundwork for linking confidence patterns to retention as we start thinking of predictive modeling. But for now, this data is telling us that ENRP is building confidence where it really counts, early and consistently. All right, so now we're taking a look at some of the components of our program. So looking at this data, we can see that our curriculum is appropriately targeting to its intended population. What do I mean? So where you see ENRP evaluation didactic subject, we ask them, how did you feel after you went through your obstetrics unit? Did you feel it was too much, too little, just right? So you can see overwhelming majority feel that the content is just right. For anybody who runs programs, this is important. You're always evaluating, as we do here, we always evaluate our programs to make sure that we're right on target. If we start seeing trends and starting to see like maybe cardiology, for example, maybe it's starting to feel too basic, we need to go back in there as, stewards of this program to see what is it that's too basic? What is new practice? The glorious thing is we're the ones changing all the content and doing everything on the back end. You don't have to do any of that. Anyway, so what else is this data telling us? So, 63% of the participants using are reporting the Lassiter. So for those that don't know, the Lassiter Clinical Judgment Rubric is a tool that we use in our program. It's evidence-based, to assess how residents are progressing through the program. So we know not every site uses it. So of course, we're not going to capture all of the data, but those that do, this is good given the variability in the site implementation and preceptor familiarity with it. So among those who do use it, the 73%, they reported that it helped them see their progression. So for us, this is good. We want to be seeing that. The data shows the program is, let's say, well calibrated, right? It's and usable in real practice. Most nurses, is majority, as I said, the content is right at the level, not overwhelming, consistent, across topics. I would urge you to take a look at that clinical judgment tool. It's widely used. They use it a lot now in nursing schools, and it's easy to apply, and it really helps nurses to see their growth. It's a common tool that everybody speaks, and it makes it easier for everybody to understand when you talk about progression. All right, so let's move over to job satisfaction. Now, here's where we are really excited. So we're looking at how they feel about the work that they do, right? Take a really good look at this. Across all measures, over 95% of the nurses agree or strongly agree that they're satisfied, they're aligned with their organizational values, and they're likely to be there in 1 year. That's great. So for those that were looking for retention and wanting to see that, this is a good indicator. So if my nurse was in this program, I can say with confidence that they are likely to stay within that year after their residency, say. So this is exactly what we want to see in our program, right? This is the thing that we think our program is doing well in helping hospitals. Um, Remember what I said that earlier on that replacing a single bedside nurse is about 50 to 80,000 in that first year, with the average being about 60,000. This is where your organizations are losing the most, right? So early career dissatisfaction shows up quickly when onboarding is weak. We're not seeing that pattern here. ENRP is really helping to protect the organization's recruitment and really training investment. You can also use this data on the opposite spectrum, right? When commitment to the organization and values align dip or the values dip slightly, those can be early indicators of turnover. So we can also look at the data about, okay, so what about the red? What about those that said disagree or strongly disagree? To me, those are nurses I want to bring in and drill into and say, okay, let's drill into this data here and find out why do they not feel this way? And is this is a point where I can do remediation? Maybe they're not a good fit. Not everybody is going to be a good fit for the ED, but at least I know that during orientation before sending them independently on the floor. So while we like looking at job satisfaction, we can all, because it's positive and we want to see those numbers, but we can also look at the other spectrum. Overall, we're seeing strong performance on the exact predictors of early retention. So these patterns help us identify which satisfaction may predict retention and which residents might be for risk earlier on. All right, so let's take a look at the participants and how they feel about resiliency. Here we're seeing strong self-efficacy, about 2/3 to over 70% report feeling confident in handling difficult tasks and performing well under pressure. What's important isn't just the positivity, it's that these are measurable and repeatable signals. So over time, data like this can be linked to outcomes such as retention, progression to high acuity areas, or your early turnover risk. So for hospitals that like to onboard in specific areas, that can kind of give you an idea of are they ready for that next progression. This is exactly how we begin moving from descriptive reporting to predictive analytics by using confidence and resilience indicators to anticipate where support or intervention is needed before nurses begin disengaging. So the durability or resiliency that we see here is known as a known buffer against burnout, against performance errors and early turnovers. So these nurses are developing the professional confidence and resilience required to stay in emergency nursing, not just survive orientation because they have support. All right. I can't wait till we get to the questions part. I want to see what people want to know. All right, well, let's shift over and I want to look at preceptors. Before I do, Nan, can you launch a quick poll for me? I want to know who currently has a formal preceptor training program for their staff. All right, I'll talk a little bit why people are filling that out. I'm sure we all know that preceptors are the single most influential factor in new nurse retention. And if you didn't know, you should know. Um, and too often we're not prioritizing and we're not providing the commitment we need to preceptors. We make them take on full patient assignments while also trying to teach safely at the bedside. We're pairing new nurses with warm bodies because there's no one else to precept. We're not always being intentional, excuse me, we're not always being intentional about who is actually precepting. But let me tell you, when you need to really make preceptor pairing a priority, high quality preceptor relationships really do matter in the success of a resident. What I love about this slide is that across every domain, ooh, let's see. Okay, good. 85% have a formal preceptor training program. That's good. Um, what I love about this slide is that across every domain, critical thinking, decision making, confidence, 98% agree or strongly agree their preceptor was effective. This signals a strong relational and instructional support during onboarding. Preceptors are helping to shape thinking and not just task completion. We also see a majority of the nurses working with 2 to 3 consistent preceptors. Throw in the chat, on average, how many preceptors would a new person be working with? Just out of curiosity, if you know. When residents have 1 to 3 consistent preceptors, that usually signals a stable unit, right? And it makes sense. If I'm paired with 5 to 6 different people, it's because I'm patchworking and maybe it has to do with because of staffing. So when they're bouncing between 4, 5, even 6, or even more, that can indicate greater operational strain. So high preceptor turnover is a known risk factor for early nurse failure, but we're not really seeing that here. It happens less often. So for those leaders on the webinar today, hear me when I say that poor preceptorship is one of the most common and expensive failure points in onboarding. We learned this very early in the program, which is why we ended up developing our own preceptor workshop that we provide with the residency program. So we're strengthening our preceptor quality and consistency in a way that helps to reduce the variability between preceptor to preceptor and what's being taught and how they're being taught. So we want to make sure that we give our preceptors the support that they need as well. Um, so we run a in-person preceptor workshop, and we have also taken our live in-person to a workshop into a virtual that we're going to probably be launching and trialing out. All right, so let me go to the next slide. Preceptor, let's switch over. There we go. Now we're looking at skills. All right, so the nurses that were surveyed in our residency program, what we're seeing here is that what we want to be seeing, strong confidence in foundational high frequency ED skills and appropriate caution in low frequency high risk. But it does point out something, right? Like they do feel confident in the things that we really care about. And then some of it has to do with, their newness to the department too. Would you expect a new grad in your ED to be comfortable setting up a chest tube drainage system or being the primary nurse in a cardiac in a cardiac arrest. But those are certainly things that we can look at and see how do we help increase those. So you can see here, nurses report the highest confidence in assessment, communication, discharge, education, and routine procedures. So this is great. This is what we want to be seeing. This tells us, from a program perspective, that our program is helping to build reliability where it matters most operationally. And then, like I said, with the low confidence, as we would suspect, cardiac arrest, chest tubes, critical care, these events they may not have a lot of exposure to these areas, or they may not be put in high risk or those situations where maybe that would be an area I would look at to start introducing them into that more. So let's take a look at stress management. So here you were looking at stress management. New nurses report fatigue and episodic workload stress, which is clearly expected, right? We all know the work that we do. I guess what's important here and what we're not seeing, most do not report persistent, overwhelming, or high ongoing stress or personal stress that's spilling into their work. So at the same time, nearly all report confidence in handling stressful situations independently. Even with the stress inherent in emergency care, the majority would still recommend emergency nursing as a career. So that tells us stress is being managed, but not driving disengagement. This is also one of those indicators that I would start looking at. If it was spilling over, then that's time to start looking at how do we help the new resident manage stress, or working with their mentor, their preceptor for stress management and coping skills. Our data suggests that our program and the hospitals running them are really helping nurses to develop the coping capacity that they need and the confidence needed to function in a high pressure environment, reducing the risk that normally escalates into burnout, absenteeism, and early turnover. Stress is present, but it's not overwhelming confidence or commitment. So to me, it's indicating a workforce that is challenging but not breaking. All right, so here we have team dynamics. I mentioned earlier that we don't just look at the learner experiences, and meaning the resident, right? We're not just looking at them. We want to also look at what's happening with the ED culture. So what is that like? So this gives us a glimpse into that. When we look at team dynamics, what stands out most, new nurses report feeling comfortable asking for help, asking questions. We want them to ask questions, right? We start getting scared when they're not asking questions. And working through stressful shifts with their peers. That's an important early signal because isolation is one of the fastest ways new nurses struggle in the ED. You'll notice slightly lower comfort around speaking up to providers, or even managing incivility. That's not surprising, especially early in practice, but it's certainly something leaders should be looking at and recognize as an ongoing culture issue, not something a single program would be able to fix, but certainly pointing that lens there. We also see debriefing after difficult cases are less consistent. For many leaders, that's familiar, and it points to where leadership behaviors and unit practices have a big impact. Overall, the data doesn't suggest a perfect environment, right? It suggests teams that are functioning with clear opportunities to strengthen support where it matters most. So our program, it's not going to solve everything, and that's clearly not what we're claiming, right? But it does give leaders a clear insight into where new nurses are struggling, where they're stabilizing, and where to target structure that can make the biggest difference in whether and when it comes to culture. All right, so this might be the last one. Okay, so what we're looking at here is practical aspects of the ED work. Can I get through my assignment? Am I juggling demands? And can I manage my time? Time management is one of the most important things that we have hospitals asking us. I guess if you had to pick, let me ask that question. You could throw it in the chat. If I had to pick one, two, or three, which questions matter most to you? Is it, can I complete my patient care assignment on time? Can I prioritize? So if you only had to pick one, I know all of them are important, but just out of curiosity. So, and toss it in the chat so I can see what matters to you. What we see, I see a lot of twos and threes. Can I prioritize? Can I organize? Yes. Yeah. What we see is that most nurses feel they can do these things reasonably well. They're not saying every shift is easy. They're also not reporting that they're not consistently falling behind or unable to prioritize. You'll notice more agree than strongly agree responses, which is what we would expect. And it suggests growing confidence without false certainty. It's interesting. Okay, a lot of twos and threes. I didn't see anybody prioritization and effectively completing patient tasks. Okay, good. All right. Oh, I guess I had one more. Okay, so this one has to do with mentors. Nan, can you launch my last poll for me, please, porfas? Do you have a formal preceptor program for your new nurses? So finally, we ask about coaches and mentors. This is a component in our program. Most leaders know that early practice is where nurses decide whether, or early in their practice, I should say, that where nurses decide whether they're going to stay or go. And that decision is shaped by who supports them as well as like how much they're learning on the job as well. About three-quarters of nurses report having a coach or a mentor. But on the flip side of that is nearly one in four do not. So that would be something I would look at in these facilities. From a workforce perspective, mentorship matters because it's one of the primary ways new nurses make sense of complex environments, navigate uncertainty, and build professional identity. So when that support is inconsistent, development becomes more variable, really. So mentorship here in our program, it's not universal. We provide suggestions and coaching, and the coaches within our program are from the hospital. We provide them with a structured approach to how to work with their new grad, but other hospitals have formal training programs that they integrate into. Did I see the poll on the formal mentorship? What was the result on that? What? Wild. That's awesome. Good. 100%. Um, very nice. Good, good, good. Okay. So, let me go to the conclusion here. Okay. So when leaders think about residency program, the question is really operational. What changes day to day? At the front end, the biggest impact in first year turnaround. Early turnover is expensive and disruptive, and anything that stabilizes nurses during that first year protects the investment you've already made in recruiting and onboarding. Over time, the stability translates into less reliance on premium labor, on contract staffing. And when you can plan your workforce instead of reacting to vacancies, staffing becomes more predictable and less costly. We also hear consistently that structured onboarding helps nurses reach independent practice more reliably, which matters for charge coverage, scheduling flexibility, throughput, and not just education. So taken all together, this supports a more sustainable staffing model and enables leaders to think about growth in a planned way rather than constantly backfilling losses. So when viewed from an operational perspective, ENRP is not an added cost, it's a reallocation of dollars that you're already spending on turnover, on vacancy, and on premium labor. So in most organizations, retaining a single nurse covers the investment in this program. There are a lot of variables that play a major role in whether new nurses stay in the ED during their first year, whether they choose to go. And hopefully, with more data, we can start helping to identify which of these are the strongest predictors of retention and where early risks emerge. So, this insight can really help us with onboarding, help reduce operational costs and stabilizing our workforce, and improves our patient care in the long run. So these patterns give us the foundation for predictive analytics, which is my ultimate goal down the road. But for now, we'll use the descriptive and helping us to really see what the future of ED nursing looks like. I want to thank everybody. I'm clearly open to having some questions. I can stop sharing for a second, but before I do, one of I'll address cost because everyone always wants to know that. So I was anticipating it. Um, so re our residency program is a subscription model. It's intentional. We did that so that, it's affordable. It's based on your ED visits. So we did that because it's helps support scale and predictability of the program costs. So it's offered a 1 to 3 year subscription, unlimited access, so enables organizations to onboard as many cohorts without renegotiating, rebuilding each year. So as I mentioned, pricing is based on ED visit and it line what else did I want to say about it? I think that's about it. If you have additional questions and want to know what it would cost for you or your ED, you can uh, scan on the right side and reach our group sales department. But I'll keep that screen up for those who want to share, but I am open to taking questions if anybody on my team want to field a couple or were most of the questions answered.
No, there is one question in the chat, Monica, that I kind of wanted to wait to the end. When you were talking about nurses staying and the likelihood of staying for a year, someone had asked, what is your control percentage and what percentage of nurses say they are satisfied and likely to be there in 1 year that do not go through ENRP? Which,
Okay, so what's our control? It's a good point to bring up because
Mhm.
our control is their retention data, which we're just so when we started the program, we were looking at program evaluation data, and then so we were looking at like we didn't bring in the Casey Fink, sorry, until help me out, team, like a year.
October 2024.
Okay, thank you. So initially we looked at program evaluation and then we were looking at their Lassiter scores. And then we thought, well, let's build in the Casey Fink survey into that, right? And then when we did, we kind of had an aha moment. We're like, okay, this is great. And to your point about what's the control, like how do we know they're improving? We ask hospitals now, we've just started doing this, is as they sign on at that moment, what is your current turnover rate? What is your current? So we're starting to build that data set now and getting the information from the hospital as soon as they sign up with us to say, okay, you tell us this, we'll plug it in, and then we'll see where you guys are. So we're comparing it to their hospital own data, but we've only been doing that just recently. And then
Also, can
go
I
for it.
add to that?
Yeah, go for it.
Just one of our other hospitals in Alabama, they're a pretty big hospital. They don't have all their new residents don't go through residency. They let them choose. And they're actually doing some data currently. So I think that's one of the questions we can ask them. Um, and, so we struggle to get data out of people regardless, as I think everyone does.
Sure.
So sometimes we do depend on hospitals to say, hey, do your facility or do you ask this question and can we see some of that data to help us kind of understand, is this program helping as well? Do those people who don't go through ENRP, what is their 1 year retention rate at your facility? So we can use that as a control group as well. Granted, that's not everyone in general, but sometimes that's what we are limited to.
Yeah, and to you bring up a good point, and that's why I was asking Katie, tell us how many people. So if you see in the chat, we've had 2,200 residents go through the program. And then when you see 232, my naive mind, I'm like, what? 2,200 should be filling out the survey. Yeah, okay. That's not going to happen. So what is that? And you do the percentage of that, but 232 is a good sample of our 2000. Of course, I would like to see more. And we do actually offer an incentive for them. Once they complete the survey, they get a 1 year free ENA membership as part of the program. So I think on our part too, we could be getting more respondents if we're pushing that more and reminding them of that. So I'm just looking through the chat to see. So we use both ENA and Vizient to test our health systems. So Vizient is a great nurse residency program that's generalized, right? So that's for the entire hospital. And many hospitals, when they're buying, looking at negotiating contracts with um, vendors and stuff, that it's a good solution. Vizient covers the entire hospital, but what Vizient doesn't do is specialty, and they'll never will, right? We've talked to Vizient plenty of times, and they're not in the they don't want to get into specialty areas, so they're never going to have like an ED residency or an oncology or anything like that. And I think that in some of our hospitals, we have seen that gap of residents who participate in those programs. We've been able to pull them out of those because they'll go through the ED residency program only. Um, what else? Any
There's a
other question?
question, what are your goal retention rates of this program over 5 years?
Um, so we've been up almost 4 years coming in April. The very first hospital that signed up with us, they maintain a above, oh, I want to say 95, but I'll go with 94 because I don't know for sure. They maintain above 94% retention rate. Um, what I would like to see is all hospitals having that. Like that's amazing. Is that the average? A lot of our hospitals have above 90% retention rate. Um,
I too would ask a clarifying question with this
or
question is, are you talking about retention rates of our hospitals utilizing the program, or are you speaking about
the
nurses
nurse.
at the bedside retention rates?
I don't know. I don't know
If you
the
can clarify, Jessica. While she's
any
so
other question. Oh,
nurses themselves,
I
not.
mean, I guess I would flip the question back to you and say, it, um, from the ENA perspective, there isn't a specific number that we would say like hospitals should have nurse first year retention rates above, X amount. Now, I know that in our Lantern application, it's something that is looked at is retention rates. But I would probably turn that back to you and say, what is from your operations of your hospital, what is the number that you want to be seeing? What is your metric that you're comparing to? I know with the Casey Fink survey, I don't know the number offhand. You can see what like an average number is. I'm wondering if someone from my team, anybody on why can't I think it off the top of my head? Um, what is the name of the program that awards residency programs? I don't know why I just left my mind. Um, to see what the average rate is of across residency programs with distinction. I wonder if they have those posted. Um, yeah, it's ANCC, but I'm trying to think of I don't know offhand. I'd have to look that up. I wouldn't know offhand. Is there an EB project in no, some hospitals do use an evidence-based project in residency, but we don't have anything that's structured for them. Um, Not specific, no. Any other questions?
There's one in the Q&A,
Okay.
and I just figure maybe we'll answer it publicly in case there's anybody else that's going to be graduating soon. They say they're going to graduate in May and will soon be a new grad. Can you point me in the correct direction that would aid me in navigating this next step?
First of all, I want everybody to do a heart emoji for Danielle. Congratulations. It is a big task. I cringe when I think of the NCLEX and having to take it again. So I think everybody should give her some heart emoji. I can't see if you guys are or not. So Heart emojis. Okay, so we on our website on the landing page, you can take a look at um all the hospitals within our program. What state are you in, Danielle? And I can help you narrow it down. But as somebody who went straight into the emergency department, California, okay. There are two hospitals in California that have our program. They're outside, they're in Fresno. So, as a new nurse or as someone getting ready to graduate and wanting to be in the ED, gone are the days when new grads were never, those of us who are older in our careers know that traditionally new nurses were not hired in the ED. Go to ICU, go anywhere, but do not come to the ED until you have at least a year of experience. That was what we used to follow and what we used to that under, that rule, so to speak. But we can't do that anymore. We don't have the experienced nurses. We don't have, COVID really did a number on us on staffing, and exposed a lot of the staffing issues that we're having. So we don't have the luxury anymore of not hiring new grads. So my stance on that is, find an ED, find an organization with a residency program. Doesn't have to be ours, right? To be successful, you really want something with a residency program that's going to have the dedicated time and paced into that. And as you're interviewing, ask the questions. What kind of tools and support do you have that can help me that can help support me with stress management? What are some available resources? How many preceptors? Those are great questions to ask. Um, Congratulations, by the way. Good for you. The two hospitals are in like outside of Fresno, Community Regional and Clovis. You're welcome. And find a mentor um mentors are really, really important to have. Any other questions?
We have someone asking if there's a way to demo the product.
Demo.
We can
Well,
show you what's in it.
yeah, yeah. Certainly show. We do what we call a deep dive where one of us walks through the program and we open it all up. Like, what do you want to see? You want to see the cardiology lecture? Do you want to see whatever component you want to see out of it? Um, Sometimes we'll provide access after, we go through NDAs and stuff like that. You might not need to demo it once you've had a deep dive with us. Or we can have you talk to other educators or directors, managers, whatever your level is, to ask them that have the program what they think of it. And that's pretty much one of the best ways. Any other questions? A shout out to our sales team who's on the call, who are business development partners who are always with us in a lot of our discussions. All right.
Andy or Amanda, do you want to connect with Katie Heinrich? She's asking, who do I connect with? And I'm not sure I'd have to scroll to see what state she's with.
Yeah. Any other questions? What we do find, so I'm kind of, I'm looking at Katie's comment. So what I do find before we end is that a lot of times educators come to us and they're like, I love the program, I want it. What do I do now? Right? Reach out to us. We are more than happy to help you pitch it, to help you break down or give you the tools so you can pitch it. Um, so, how do you talk to your director, your manager, or the CNO, or whoever, to explain what the program is? We can help walk you through that. We've done it in the past. So feel free to reach out to us. All right. Any other questions? Or Nan, are we all good?
I think we're all good. I don't see anything. I'm watching the chat. They're putting some links and stuff in there talking about getting the information. They will be able to see a recording of this. So keep your eyes out on your email and they'll let you know when you can do that.
There was a question about this being recorded and where they will be able to find it. What,
Yeah, and I think that they just answered that
Yeah, we usually record it and put it on the ENRP landing page so
the
anybody
landing
can,
page.
yep,
Right.
take a look at it.
Yep.
I can also put my email in the chat, but if there's any other questions that you wanted to ask me.
Sorry, there's one more question
yeah.
about any recommendations for using this at a corporate level, if you have multiple hospitals in one system. Mhm.
We love multi-hospital systems. We have a lot of partners that do it. Penn State, Yale, New Haven. So we have a hospital. So what I would recommend is reaching out to us and making sure you know who those stakeholders are at each of those facilities, and get everybody on one call so that we can walk through the program. Um, yeah, Andy. Yep, we can also provide references of other hospitals that are in the program. Anything else? That's it. I think the last thing I'd say about when you want to take it to the corporate level, like looking at, multi-system hospitals, because we've had hospitals that will what's it called when they've created their own float pool because everyone's been trained the same way, right? So one person at hospital A can go to hospital B, and so some systems have pitched that approach, but there's a lot of different things. And once we learn a little bit more about what your needs are at your hospital, then we can kind of help you with how you approach the C-suites. All right. This was fun. Thank you everybody for joining. If there's no other questions,
All right. I'm going to go ahead and end the webinar. Thanks
all
everybody
right.
for being
Thank
here
you so
today.
much, everyone.
Take care.